see if that works. Did you guys get a notification that you're recording?
Yeah.
Yes, good. All right. Feel free. Show is yours.
Okay. Fab. Thanks so much, Jack. So I'm Eugene. This is Heine. You get 2 for the price of 1 in terms of presenters for this. So we're going to be doing this presentation together. And first lecture of the day, great way to start, the gastrointestinal system. So let's get straight into it. Okay, so this is what we're going to be going through today. Obviously, GIT is like such a huge topic. So there may be things that we just miss purposely. But if that's the case, and there's anything in particular that you want us to go through, just yell out, type it into the chat, anything. We made this presentation with a lot of resources, and these are the really key ones that we did. And obviously massive thanks to Jack and Cindy too. So if you have any questions throughout, please just ask. Getting straight into the heavy stuff. So anatomy first. A bit of surface anatomy. At this stage, it's just important for you to really understand what each of the terms kind of means and what it represents in terms of where it is on the skin, and then begin to have a think about, okay, well, where could the pathology be if the pain or discomfort or anything, the symptoms are presenting in that area. So key ones that you want to be aware of are just hypochondriac, just below the ribs. So these regions here. Epigastric, think stomach. So right here, smack bang in the center. You often hear right upper quadrant as well instead of right hypochondriac. So just be aware of that. Umbilical, obviously around the umbilicus. These are usually referred to as the flanks, and then usually you're thinking kidneys there. So then this is your right iliac fossa, or you'll see riff, and then left iliac fossa, or you'll see lif. So you want to think about what you can find there as well. And then this is often suprapubic region, this bit here. So starting with the layers of the abdo wall, we just want to be aware what they are. And the reason for that is if you are to have an exam question on this, it's usually something like, what layers will the surgeon's scalpel go through in order to get to X? So coming from outside, so your skin here, to deep. So this is like going to be after this is going to be your visceral peritoneum and then your viscera. So we've got your skin. Then we've got 2 layers of superficial fascia. And the reason for that is that the scarpus fascia, that deeper, slightly deeper layer, is your substitute for deep fascia. So in that kind of way, you can remember that scarpus fascia essentially looks a little bit like deep fascia. And so it's going to be thin and membranous. Whereas your campus fascia, which lies above that, is your normal, like thick adipose layer. Then you've got your abdo-wall flat muscles. You've got your external oblique going to your internal oblique, makes sense. Then transversus abdominis. Then you have your transversalis fascia, extraperitoneal fat, and then your parietal peritoneum. So a little bit more on these muscles. We've put there like what they do here. You can read up on that and learn that as well. It's not super examinable. They don't test it that much, but it's kind of just good to know what they do. So we will gloss over that. Important, really important for us to understand though, is the idea of the rectus sheath and the arcuate line. So as you can see here, the rectus sheath comprises 3 different layers. You've got the aponeurosis of external oblique, aponeurosis of internal oblique, and aponeurosis of transversus abdominis. The arcuate line is this arbitrary line that is taken, sorry, it's not arbitrary, but sometimes it can feel like that, that's taken if you measure 2/3 of the way between the umbilicus and the pubic crest. So it's 2/3 of the way from top and then 1/3 of the way from the bottom, if you want to think about it that way. So above the arcuate line, things are a little bit more messy. You want to think that it's kind of split half and half. So you're going to have your external oblique aponeurosis and half of your internal oblique aponeurosis anterior to rectus abdominis, and then everything else obviously is going to be posterior to that. So it's going to be your other half of your internal oblique and then the aponeurosis of transversus abdominis. Below the arcuate line, things are a little bit more simple. Everything's just in front of rectus abdominis. So all of the rectus sheath lies anterior to rectus abdominis. So a bit early in the lecture, I think, for a question, but we put one here anyway. Give this a quick read, and then I think we said about maybe like 10-ish seconds of thinking, and then we'll move on to the answer. So trying to make this question clinically relevant. So if a surgeon wants to remove a segment of rectus abdominis, so we want to get to rectus abdominis and we are superior to the umbilicus. So think about where that places you in terms of the arcuate line. We're going to be superior to that as well. So what are the layers that lie anterior to the rectus abdominis, superior to the umbilicus? So it'll be the external oblique aponeurosis, and then awesome. Thanks so much, guys. Yeah, so it is going to be C. And so again, don't really have to go through this again, but just refer back to those diagrams again. Really good, really useful to visualize what's happening. So quick word on the posterior abdo wall. It's not assessed as much as the anterior abdo wall and the whole arcuate situation. The arcuate line situation in the rectus sheath. But now we've got different forms of the word arcuate here. We do just want to be aware of what the median, medial, and lateral arcuate ligaments are, because if you just don't know them, when they ask a question, you're not going to be able to answer it. So it is one of the things that we just have to remember. The way we can kind of do this is just have this picture in your brain. So know that the psoas muscle is the more medial one, kind of, compared to the quadratus lumborum. And so that way you'll remember that the medial arcuate ligament has to do with the psoas muscle, whereas the lateral arcuate ligament has to do with the quadratus lumborum. You can also pair the L and the L for lumborum and lateral if you want. But if you kind of remember the umbilical folds, I'm jumping around a little bit, but this kind of relates to that, because if you remember, the medial and the lateral are kind of like vessel-y situations, but then the median one is different. It's like your urachus. So here, the median one, the median arcuate ligament, is also different. It's not so much like a thickening of fascia overlying one of the posterior abdo muscles. Instead, is this here, created by the right and left crust of your diaphragm. Which wraps around where the aortic hiatus. Cool. So regarding innervation of the anterior abdo wall, I won't speak too much about this. It's mainly kind of just an introduction here. So when we get to talking about somatic and visceral pain, it makes a little bit more sense. So we do have sensory innervation, obviously, to our anterior abdo wall, and it's usually dermatomal. So the nerves that supply your anterior abdo wall are going to arise from your spinal cord at T7 to T12. If you remember that T10 is the dermatomal distribution around the umbilicus, you'll just be able to figure out what lies above and what lies below that. So a little bit of clinical relevance here obviously is going to be when we talk about visceral and somatic pain, and also when you have reactivation of your varicella zoster virus or chickenpox in the form of shingles or herpes zoster. It's going to be along this dermatomal distribution. And so notably, it's not going to cross the midline at the front or the back. It's just going to be over one or like a few dermatomes on one side. Okay. So this is a little bit of a heavy slide. Apologies. But it has a lot of really important folds and ligaments for us to understand. It's not important just for us to understand where these came from embryologically, but also to understand what runs in them, if anything does. And often it's going to be some form of artery, and the way they'll phrase this in an exam question is like, the surgeon wants to make sure they don't nick an artery, or the surgeon wants to specifically clamp or ligate an artery. Which ligament are they going to be looking for? So we've kind of summed this up in a table here. Like I touched on a little bit before, you want to know about the umbilical folds. The median and medial ones are related to like their developmental origins. So the median one, think about it, you've just got one in the middle, so it's not going to be a paired set of arteries. So it's going to be the obliterated urachus. And then your medial umbilical folds are going to be the umbilical arteries, whereas your lateral umbilical folds are different. They still hold patent vessels. So that those are your inferior epigastric vessels. And they also form the lateral border of Hasselbalch's triangle, but we'll go through that a little bit later as well. Then you can kind of group the falciform and the round ligament together, both kind of in the liver area. So the falciform ligament is your most ventral part of the ventral mesentery. So anterior abdo wall to liver, and then the round ligament is just kind of like the base. So the inferior continuation of the falciform ligament. Then the second part of your ventral mesentery is going to be the hepatogastric ligament. So that's the liver, if you can imagine, to the lesser curvature of the stomach, because as you'll remember from Michelle Lazarus's amazing embryo lectures, that the stomach kind of swivels around, and so the lesser curvature faces the liver and the greater curvature ends up facing the spleen. So the hepatogastric and the hepatoduodenal ligament together comprise the lesser omentum. Comprise the what do you call it? The lesser omentum is the word that I meant. I don't know what I was looking for. Notably as well, we just want to remember that the hepatoduodenal ligament runs along that free border of the lesser omentum and contains the portal triad. We'll touch on this again later. Then moving to your dorsal mesentery, you've got the gastrosplenic ligament and the splenorenal ligament. We just want to remember that the gastrosplenic ligament, so we'll go through arterial supply to the GIT in a little bit, but remember that the gastrosplenic ligament is going to contain your short gastric arteries. This is examinable. So short gastric arteries, you can kind of remember, they come from like this splenic artery, and then they have the word gastric in them, so gastrosplenic. Then we want to know the ligament of Treitz, and this is really clinically important because this is what divides upper GI from lower GI bleeds. So if it goes proximal to the ligament of Treitz, it's an upper GI bleed, and if it's distal to that, it's a lower GI bleed. And this ligament attaches to the duodenum at the duodenojejunal flexure, so just separating the duodenum and the jej. So diaphragmatic openings, again, this is just a little bit of a memorization game. Quick hacks, which I'm sure you've probably heard before. So T8 is the caval hiatus because vena cava has 8 letters. T10, esophagus, 10 letters. T12, I'm sorry, I don't have a nice way to pair T12 with aorta, but it's the one that's left if you remember the previous two. Another way you can kind of think about this is that if you remember the diaphragm, it kind of domes up and, oh, there we go, aortic hiatus equals 12. Beautiful. I'll just quickly explain that anyway. That actually works. I don't know why I never came across that. Thank you. So if you remember, the diaphragm kind of domes and it attaches really inferiorly, posteriorly. So if you remember that your aorta runs quite posteriorly as well, like pretty much right at the back, then it's going to have the lowest insertion point too. So just a few things that run with it that you can read up on. Sorry. So these are some spaces that we want to be aware of. We'll touch on intraperitoneal and retroperitoneal later. But in particular, we want to know that if there is fluid in the peritoneal cavity of some sort, whether it's like just like gunk or not, where it can pull. And if you just think about it, they're going to be in different locations depending on whether or not we are standing up or sitting up or when we are lying down. And the reason for that is just gravity is going to move it to the lowest point. So if we are sitting up or we are standing up, the lowest point in males is going to be between the bladder and rectum. Rectum, recto, bladder, vesicle, recto, vesicle, pouch. Whereas in females, it's going to be between the uterus and the rectum. So recto-uterine pouch, also known as the pouch of Douglas. You'll see them interchangeably. Whereas when we are lying down, it's going to collect here. It's important to note that it'll collect on the right in the hepatorenal pouch. So hepatorenal has to be on the right? We don't have a liver. Most of us don't have a liver on the left. So hepatorenal pouch here, also known as the pouch of Morrison. Transpyloric pain, transpyloric pain. I mean, kind of. Anyway, transpyloric plane is technically the level of the pylorus at the stomach. And so it should be at around the L1 vertebrae, but obviously we have lots of things can move things around. It's not always going to be perfect like this, but when we learn anatomy, this is what we learn. Heaps of things on the slide here that are meant to be along this plane, but the key ones we want to be aware of are these first four actually, as well as the hyla of the kidneys and the spleen. Okay, so inguinal canal. We all love the inguinal canal. So it is the pathway which extends inferomedially from the abdominal space, either going to the scrotum or the labia majora in males and females respectively. So you can spend time learning what's the roof, and all the different walls. And I think there's a really good mnemonic for this. It's like MALT, M-A-L-T, if you want to. But we're not really going to focus too much on that today because they tend to assess the content of it just a little bit more. So in terms of the contents, you've got the spermatic cord in males, round ligament in females. We'll touch on the somatic cord a little bit more in the next slide. And then we've got two nerves. We want to be aware that there are only two nerves going through the inguinal canal. So usually in an MCQ, they're saying a particular nerve is damaged in some kind of inguinal canal surgery. You can already limit down your options. Limit down your options to just two of the nerves. So ilioinguinal nerve provides sensory innervation to the genitalia, and genitofemoral, look at the word. So it has genital area and femoral area as well. So we're thinking the anterior scrotum in males and labia majora in females, as well as the thigh. So somatic cord here, again, we do just need to know what runs through it. So if you recall from embryology, in the developing fetus, the testes actually start kind of inside the abdomen, then it's going to like almost herniate or just push through the anterior abdominal wall to come and rest in the scrotum. So the way I kind of remember this was vasculature, there are 4 important things, others, there are 3 important things, and nerves, there are 2 important things here. Particularly, we want to note that the processus vaginalis should fuse though. And if it doesn't fuse, we end up with pathology, or we can. Yeah, that's pretty much it. Everything else is on the slide. So quick question. We've got a 75-year-old male who presents post-inguinal hernia repair. So we've had some kind of surgery on the inguinal canal. We're already limiting our options to 2 of the nerves with burning pain in the groin and medial thigh. Which structure was most likely affected during the surgery? Okay, we might just speed ahead. Yeah, great work, guys. So it's going to be the genitofemoral nerve. Remember, take a look at the name of the nerve again. If we've got pain in the groin and medial thigh, it's going to be genitofemoral nerve. Okay, so we do need to be aware of how the abdominal wall layers translate to the scrotum as well. But frankly, this is just a lot of kind of just memorizing. And I know there are like diagrams that you can make and everything as well, but we're not going to focus too much on this because I don't think there's too much that I can add. Everything is on the slide here. The key thing that I use to remember this is that transversus abdominis just becomes kind of nothing in the scrotum. It just doesn't. So that way you can just kind of work it out and either go from out in or in out, doesn't really matter, but everything will sort itself out. So I put this in here just because it is kind of pathognomonic, and you just want to be aware that bag of worm sign equals varicocele, which is just kind of varicose veins of that pampiniform plexus of veins leaving the testes to go back into the rest of the body. And you'll hear as well, it's more common on the left side because of the whole left side, left testicular vein entering into the renal vein situation at a 90-degree angle, which means there's a little bit more blood in the left testicular vein, which means a little bit hotter, so it sits a little bit lower, which means that the left pampiniform plexus is more prone to developing this condition. Just remember, bag of worm sign equals varicocele, and remember that left testicular vein into left renal vein and right testicular vein straight into IVC. So this is really important. Inguinal hernias. Hasselbalch's triangle, we want to be, if you know one triangle on the body, please let this be that triangle, I think. So we have 3 borders, a medial, lateral, and inferior border. The inguinal ligament is going to be the inferior border. And if you just remember that, you'll be able to work everything else out, which means that the lateral border of rectus abdominis will be the medial border. And then lateral to that, the lateral border is going to be the inferior epigastric vessels, which we will remember is also the lateral umbilical fold. Now, if we take a look at this diagram, it makes it really clear that the deep ring of the inguinal ligament lies lateral to Hasselbalch's triangle. Yeah. So if we have a hernia, an inguinal hernia that goes through the deep inguinal ring, that goes through the inguinal canal, that is what we call a indirect inguinal hernia. If you can think about it, it's kind of taking a path. It's like almost like a cop out. It's like I don't have to go through any walls or anything, just lining through the canal. So it's indirect. It's not just herniating straight through the abdo wall. So that is lateral to the inferior epigastric vessels. And this happens, if you remember when we talked about the somatic cord before, if the processus vaginalis does not close and remains patent in the adult. You can remember that a direct inguinal hernia lies medial to the inferior epigastric vessels, which means it will happen in or through Hasselbalch's triangle, because pair the D and the M. It's like sliding straight into the DMs. Nobody really wants it, but it happens anyway. So we do want to be aware of some terminology that can be used. with inguinal hernias. If it's incarcerated, all that means is it's irreducible. So when they lie down, when you try and push it in, it doesn't just slide in really easily. If it's strangulated, this is bad. So it implies bowel ischemia. So it's just really, really caught there and blood's just not circulating there anymore. Femoral hernia, I won't speak too much about this, just know that it happens more commonly in females. And if you recall navel, the nerve, artery, vein, empty space, lymphatics in the femoral triangle, it just slots into that empty space situation here. Rest of the info is on the slide. We do need to be aware that testes and scrotum have different vasculature, innervation, and lymphatic drainage. We need to, I was trying to pick the key thing from the slide and then I didn't bold anything. So, it's here. We want to be aware that because the lymph drainage through the inguinal canal goes to the parietic lymph nodes rather than being the palpable superficial ones in the inguinal region first, testicular cancer can present initially as having spread to the lungs first as that first organ. And your first palpable lymph node is going to be that Virchow's or that left here, left supraclavicular one. Okay. So this is where embryology does become a little bit important. We want to know which structures are foregut, midgut, or hindgut. So foregut is going to be from the mouth to D2 of the duodenum. This refers pain to the epigastric region. So just think foregut, high up. Midgut is going to be around the umbilical region where they refer pain, and hindgut to the back end. So lower suprapubic region. Notably, we want to remember that this line here, 2/3 of the way along the transverse colon, is what splits the midgut from the hindgut. So, quick question, where would a direct inguinal hernia with bowel involvement most likely refer pain? So have a think about it. It's a bit of a two-step question. You want to think about if there is bowel involvement in an inguinal hernia, which part of the gut will it be? Will it be foregut, midgut, or hindgut? And because of that, where will it refer pain? We might just speed ahead. Yeah, awesome. So it's likely going to be the small gut that herniates through. And so because of that, it's going to refer small gut, midgut, umbilicus. Cool. Again, just a lot of text on this slide. Everything that, and I think we're pretty familiar with all of this terminology by now. The main thing that I wanted to point out here, because they do tend to like to ask about it a little bit more than everything else, is that the majority of the pancreas is secondarily retroperitoneal, but the tail, which I'm sure you've heard of, tickles the spleen, which is intraperitoneal, is also going to be intraperitoneal. So greater and lesser omentum still stumps me a little bit to this day, I think. So I have simplified it a little bit and hopefully this makes sense. So this has the kind of key stuff that you need to know. The lesser omentum is formed, as we said before, by the hepatogastric and hepatoduodenal ligament, and it forms the omental bursa or the lesser sac. This sac lies posterior to the stomach. So if you remember this, you'll be able to answer any question that says there is a bleed from the posterior stomach into a space. Which space is it? Lesser sac. Cool. So the greater omentum is the greater sac, so the greater omentum forms the greater sac, and it comes off the greater curvature of the stomach. And so that's going to be kind of in front there. We want to be aware of something called the Pringle maneuver, which is where they clamp off the portal triad. Actually, yeah, they do. And where this is located is going to be in that free border of the lesser omentum, which is also known as the hepatoduodenal ligament. So associate all these terms together. So vasculature, really, really, really quickly. Won't go through all of it because it's all in the slides and the diagrams kind of explain everything that we need to know as well. So just remember that the celiac trunk has 3 main branches: your left gastric artery, the splenic artery, and the common hepatic artery. The way that they tend to ask questions on this is if there is a perforation, if there's a perforation of a particular artery, a perforation of a particular duodenal or gastric ulcer, which artery is it most likely to hit? So just look at how it tracks. If there is perforation of a posterior duodenal ulcer and it just perforates and it starts spitting out blood into the cavity somewhere, so it's eroded kind of, if you can imagine, we started the mucosa and we rode out slowly until we get to one of these big arteries. That's going to be the splenic artery if it's a posterior stomach one. If it is a posterior duodenal one, it's going to hit that gastroduodenal artery. Okay, cool. So and celiac trunk arterial supply to full gut comes off abdominal aorta at T12 versus SMA, which is classically arterial supply to mid-gut, comes off at L1. Again, all the info is on the slide here. I'm mainly going to be talking about the middle colic artery and how it relates to clinical pathology, because we've got the middle colic artery that comes off the SMA and it anastomoses with the left colic artery, which comes off the IMA at what they call the marginal artery. Now, this is called a watershed area because it has dual arterial supply. This kind of paradoxically actually makes it most prone to ischemia. So during periods of hypotension or just hyperperfusion to the gut, this area, the splenic flexure supplied by the marginal artery, is going to be the area that's first affected, or the area that you're most worried about not getting blood supply. And the reason for that is it's kind of like, because both middle colic artery and left colic artery are supplying this area, the left colic is like, the middle colic can do it. And the middle colic is like, no, the left colic can do it. So at the end, neither one of them ends up doing it, as in like ends up providing blood to the area. And so because of that, prone to ischemia, just remember that. So yeah, skipping through that. So we already talked about IMA. So IMA is the arterial supply to the hindgut, again, anastomoses with the SMA in that watershed area of the splenic flexure, arises at L3. Okay. We might actually skip this question for the sake of time, but all the answers are on the slide, so you can look at them later. Venous drainage, the systemic one, the IVC one, kind of just tracks all of the arterial supply that we just talked about, so I won't touch too much on this. Portal venous drainage, we do just want to comment on, because this is commonly why colorectal or bowel cancers metastasize to the portal system, because a lot of the venous blood from the gut just goes to the liver. Notably, we want to remember that the IMV goes to the splenic vein first. So the portal vein is only directly made up of the SMV and the splenic vein, because the IMV has already gone into the splenic vein. Okay, so this is quite a big area, but we just want to remember regarding autonomic innervation to the gut, where sympathetic synapse and where parasympathetic synapse. That is the kind of key thing that we want to remember, as well as which kind of bundles of nerves supply which areas of the gut. So you'll remember from first year, the sympathetic outflow is from the thoracolumbar area of the spine, whereas parasympathetic, think about like either side of sympathetic. So it's going to be top and down. It's going to be cranio, so brainstem, or sacral, S2, S4. Sorry. So there are two ways the sympathetic outflow can occur. The first is just through, leaving the spinal cord, just passing through the sympathetic trunk, and then leaving that, going to the paravertebral or prevertebral or para-aortic ganglion, and then synapsing there before going to the gut. So that's the first option. The second option is we leave the spinal cord, we go to the sympathetic trunk via the white rami communicans, then we take a little bit of an elevator ride, either up or down. Then we synapse at our new level. Yeah, so we synapse at our new level here, and then leave as postsynaptic via the gray rami communicans, and then just pass through the para-aortic and prevertebral ganglion without synapsing. Let me know if that doesn't make sense, but that's quite important to remember, those two different options. And so everything else that needs to be kind of explained is on here. And just remember that if you want to differentiate between your sacral splanchnic, which is sympathetic, just pair S and S, versus your pelvic splanchnic, which is parasympathetic. So regarding foregut, mid, hindgut, all of that is on the slide. I think it makes sense the way that we presented it, hopefully. So if you've got any questions, just reach out though. But for the sake of time, we're going to just move on. We might actually move past this question as well, I think. But if you've got any questions about that, just reach out later. So visceral and somatic pain, just want to understand what this is. Visceral pain is poorly localized because it's not actually really sensory fibers that are kind of, or like dedicated pain sensory fibers that are picking up on this pain. Because of that, it's just kind of when you've got distension or stretch of a viscera, or inflammation of a viscera, before it irritates any of the parietal peritoneum. And so this is going to depend on the embryological origin. So the whole epigastric, umbilical, and suprapubic thing we were talking about before. Classically, this pain is going to be rolling around trying to get comfortable. They're going to be in a lot of pain, but they're not going to be in the same type of rigid, guarding, irritation of parietal peritoneum pain that you get with that kind of irritation of the parietal peritoneum. So that your patient will be like just completely still, like a board. Okay, and this classically, you'll be examined on this with umbilical pain in early appendicitis, migrating to the riff in later appendicitis, because the appendix lies in the riff. And so when it's been super, super, super inflamed, it gets swollen, it gets angry, and it's going to irritate the parietal peritoneum overlying the riff. Okay, moving on. Basic principles of histology. Again, I think we will just, everything that we need to know is on the slide here. So we're going to move past it quite quickly. Do note the difference between serosa and adventitia. It helped me just to remember the serosa is literally just visceral peritoneum. Okay, so physiology. The esophagus has 2 layers of muscle that work in conjunction to move food from your mouth into your stomach. The inner layer of smooth muscle will be the circular smooth muscle, and so that contracts behind the bolus of food to prevent backflow. And then the outer layer of muscle, which is longitudinal smooth muscle, works ahead or kind of around the bolus to kind of just make everything easier for the bolus to move forward, because it contracts, and so the bolus can move forward a little easier. Neuronal control of the gut. We want to know that there is a gut brain, and it's called the enteric nervous system. And there are 2 main plexi that we want to be aware of. The myenteric plexus, which lies between those 2 layers of smooth muscle, which we actually just talked about before, the circular and longitudinal muscle, and then the submucosal plexus. And so they're named really, really aptly, so that we can actually remember where they lie. Myenteric plexus, muscle; submucosal plexus, submucosa. So if we remember where they are, we will remember what they do. So myenteric plexus is lying in between the muscle. It's going to help with that contractility. It's going to help with the motility. Submucosal plexus lies in the submucosa. It's going to help with those secretions. Okay, yeah, I think pretty much everything else is there. Should we, Heini, do you want to do this one, or should we? How are we going for time? No, we are not doing this one. We are sorry about that. Okay. Gut motility. We want to be aware that there are segmenting contractions in the migrating myoelectric complex in the small intestine. And then the large intestine, there are mixing and haustral contractions and mass movements. Won't really go into this, but remember that those that are triggered by stomach filling are top and bottom. That's how I remembered it. So segmenting contractions in the small intestine and mass movements in the large intestine. Okay, moving through that as well. Heini will go through this later. Yeah, everything is on the slide. Okay, sorry, it's taking so much longer than I thought it would. I need to speed. Yeah, we might actually move through that too. So defecation reflex. Important thing just to remember here is that we have, we are able to control our external anal sphincter. So if I do not want to take a poo now, I will not take a poo. And the reason for that is because that is controlled by signals from the cerebral cortex and your somatic motor nerves, whereas the internal anal sphincter is under parasympathetic control. And so, yeah, that's pretty much all I wanted to say there, actually. Everything else is on the slide there. Okay, cool. Organs and clinical conditions. Starting off with quick case. We have a 60-year-old female with a BMI of 35. She presents with a history of epigastric pain associated with dyspnea alleviated by 5 minutes of rest. What is your top differential diagnosis? Okay, we'll speed straight ahead because this one's actually not an abdopathology. We just wanted to remind you that things like, AMIs or acute coronary syndrome can also present in a little bit of an atypical way. So always take a really, really, really close look at the associated symptoms and the pain history, because that'll give you massive clues, and lean on that as well. Okay, so starting off with the esophagus, we might actually whiz through that. The key thing that we want to remember about esophageal anatomy is that normally it has stratified squamous epithelium. And so this is really clinically significant because in Barrett's esophagus, when you've got that chronic kind of reflux, it causes a change in the epithelium into simple columnar. Okay. So if we have a 50-year-old female presenting with epigastric burning pain after meals and a dry cough at night, what is your top differential? It should be good. Oops, we always pass that actually. Take a moment to appreciate sorry, okay, moving on. So GORD is when we have a reflux of stomach contents. Do you remember the stomach produces this acid into the esophagus, and it's going to cause irritation there. It's associated commonly with a hiatus hernia. So if part of the stomach herniates above the diaphragm and failure of that lower esophageal sphincter. Typically presents as that case that we just gave, and Heini will go through treatment later. The main thing we want to be aware of here is a complication of long-term reflux is Barrett's esophagus. So just remember, we go from simple stratified to simple columnar. And that's like a precursor to cancer potentially. So 2 types of hiatus hernia we want to be aware of. Sliding hernia is more common. It's when the cardia of the stomach slides above the diaphragm. And so the GOJ actually moves up as well. Whereas in a paraesophageal hiatus hernia, you've just got the fundus herniating up, but the GOJ remains at the same level. A lot of this is, a lot of the times people have these types of hernias, but it's completely asymptomatic or they just have GORD. So just be aware of that. Okay, Heini, you're up.
Sorry, guys, we are whizzing through these, but if you have any questions, just let us know as we go along. Cool. Stomach. Eugene, do you want to just keep sharing slides? Great. Let's quickly whiz through anatomy. I'm sure you guys are all aware of this and you guys have already covered this, but we have 4 main divisions. First, we have the cardia. Basically, we've got that superior opening at the T11 level. Then we've got the fundus. It's round, often gas-filled. It's the superior most portion. And it's made when there's a horizontal line is drawn from the angle that it forms with the cardia. So that's the angle of his. And then we've got the body, the largest, most central portion. You guys can see from the diagram. And then we've got the pylorus, which is basically connecting the stomach to the duodenum. And it also demarcates the transpyloric plane at the level L1. We've also got 2 curvatures. We've got the greater and the lesser curvatures. The lesser, it's shorter, obviously, and it's attached to the hepatogastric ligament. It's supplied by the left gastric artery and the right gastric branch of the hepatic artery. And then we've got the greater, so this is longer. It's attached to the gastrosplenic ligament and the greater omentum. It's supplied by the short gastric arteries and the right and left gastric epiploic arteries. Cool. Honestly, I won't be going too much into anatomy if I'm being completely honest. But I think we'll just skip it. It's all on the slides though, guys, I promise. But yes, that's the So we have a 55-year-old male with chronic arthritis who presents with sudden onset severe epigastric pain and hematemesis. Pretty classic buzzword presentations for peptic ulcer disease, and we're going to go into that a little bit more. Please appreciate the memes. Cool. So peptic ulcer disease, we basically have these really sensitive, really raw patches that form a break in the lining of the stomach or the duodenal. So duodenum. So you either have gastric ulcers or duodenal ulcers. Gastric ulcers are more common in those older than 50. However, duodenal ulcers, I think, are more common in general. Your symptoms, it's basically just going to be that buzzword presentation, a really burning epigastric pain. For gastric, it's going to be less than an hour after eating. For duodenal, it's going to be 1 to 3 hours after eating. And that just is like about where the food has like moved to at that point in time. They can have bleeding, so that will lead to hematemesis or melena. Hematemesis often described as coffee ground vomit, and melena is like that black tarry stool. They can also get reflux and symptoms of indigestion. Complications, basically perf. We don't like that when there's a perf. Not good, not great for the patient. And if you do an erect chest x-ray, you can see that free gas under the diaphragm. Not a great sign. We don't like that. And I think, do I go into, yes, if we go to the next slide. Yes, basically causes, 2 main ones that you want to know that faculty wants you to know and always will test you on: infection, H. pylori, very, very, very typical, as well as NSAIDs, which will give you that presentation that we just, the one like that we started the case with. So someone who's got like chronic arthritis or something, who's obviously going to be taking lots of NSAIDs or something for pain. Great, let's go through H. pylori infection. So it's a gram-negative rod. Complications, obviously, peptic ulcer disease, gastric cancer. How we diagnose it is through this thing called a urea breath test. You can see it here. And basically treatment, triple or quadruple therapy. This does get tested very, very often. Faculty does want you to know this and will examine you on it. So triple is your first line, and you can remember this through ACE. So that's amoxicillin, clarithromycin, and a PPI, usually esomeprazole. And then you've got your quadruple, which is given to those who are clarithromycin resistance. So that can be remembered through TOMB. So that's just tetracycline, once again, a PPI, metronidazole, and bismuth. Sorry, guys, that was really, really fast, but small intestine.
Okay, cool. Moving on. Sorry, I was just in the process. If you've asked a question to me, I will get back to you in a sec, but small intestine anatomy, we want to be aware that there are 4 sections, D1 to D4. Just remember which are intra and which are retroperitoneal. So if you think about it, D2 and D3 will have the transverse colon overlying it. Transverse colon is intraperitoneal, which means D2 and D3 get shoved to the back, retroperitoneal. D2 is where the sphincter of Oddi empties, and that's where you get your bile and pancreatic secretions into the major duodenal papilla, which is a part of D2. It also has Brunner's glands, which secrete alkaline fluid, which makes sense because we want to kind of combat all of that really acidic chyme coming from the stomach. Yes. We already talked about a lot of this. Do be aware that the JEG tends to have longer vasa recta and less complex arcades. So if we just kind of channel this diagram into our brain, you will remember it. The ileum, we want to know that the ileum has Peyer's patches. So that's kind of the lymphatic tissue, so part of the immune system there of the gut. And it absorbs vitamin B12 and bile. Remember this, because any pathology impacting the ileum, causing inflammation or malabsorption there, will mean that you could be deficient in vitamin B12 and you don't reabsorb bile. Meckel's diverticulum, something to be aware of. So it's related to embryology. You'll remember that the gut tube does have a connection to the umbilicus. And this is that embryological remnant. If it's present, it will be between the ileum and the cecum, just because that's where that connection is. If we have a 25-year-old female presenting with cramping abdominal pain after eating and chronic diarrhea and iron deficiency, what is your top differential? We'll go through this condition. It is called celiac disease. We actually will skip that. Yes, okay. So celiac disease is an autoimmune disease, which means it's associated with, or, could be a higher risk of celiac disease in patients with other autoimmune diseases as well, like type 1 diabetes, like thyroid disease. Pathophysiology is a little bit specialized. We just want to be aware that it results in, because it's activating the immune system and causing inflammation in that area of the small intestine, mainly the duodenum first, it will result in atrophy of the villi. And so you'll often see that as like flattening, blunting of the villi, hypertrophy of the crypts, and you'll see lymphocytic infiltrate in the area as well, just because it's an autoimmune reaction. Okay, the main way it's diagnosed is with a duodenal biopsy on a gluten diet. So they still need to be on gluten, because if they're not, these changes kind of are not present anymore. And you'll see those changes that we talked about before. Celiac serology can also be done for various antibodies, commonly associated with a nutritional deficiency. So in the way that we presented the case. So when you see a nutritional deficiency, think, is there malabsorption? And then follow the symptoms down. Okay, we might actually skip through ischemic colitis and IBD. Yeah, is that all right with you, Heidi? I think we've touched on the more important bits. Okay, so large and there we go. Moving on to the large intestine now. But if you do have any questions over the bits that we've glossed over a little bit, just shoot us a message after. So large intestine, we want to be aware, we've got the cecum, ascending colon, transverse colon, descending colon, and sigmoid colon. We've got the vermiform, like worm-like appendix, just the appendix really, coming off the cecum there. If we recall back to the SMA branches, this appendix is supplied by the appendicular artery, which comes off the ileocolic artery, which comes off the SMA. So just track that back a little bit, because they can ask about this. The convergence of the taenia coli, which are those 3 straps of muscle around the large bowel, converge at the appendix, and that's often what it's used to find, what is used to find it in surgery. Notably, we want to point out that when we take an abdo x-ray, the way that you can tell the difference between large bowel and small bowel, other than where it's located, with large bowel tending to be more laterally or to the sides, is that the haustra, which are those little, sacs in the large bowel, you can see that the markings that they make don't go all the way around. Whereas in the small bowel, I like to think about small bowel, it's like a stack of coins. So, the plicae circularis do go all the way around there. Okay. Quick word on sigmoid volvulus. And so regarding the sigmoid colon, it does have its own mesentery, kind of like the appendix. So appendix has mesoappendix, sigmoid colon has the sigmoid mesentery. Because it has a mesentery, it's more mobile. And so it can rise up really high and twist. And if it does twist, we can get sigmoid volvulus from it. Presents typically as, constipation. Basically, we've got a blockage there. Nothing's going through. Vomit, constipation, pain, those kinds of things. And very, very pathognomonic for this is you see an abdominal x-ray that looks like this. It's called coffee bean sign. It looks like a coffee bean. Sigmoid volvulus is your diagnosis. Yeah, we can just take a read of this because I think very, very common presentation of acute appendicitis. Do remember though that when you are taking history, you suspect acute appendicitis or any pathology really, ask whether they've had that organ surgically or that part of the body surgically removed. If they don't have an appendix, they can't have acute appendicitis. So like I've been caught out before. So just make sure that you find out. Okay. So acute appendicitis becomes important regarding anatomy because this is that whole starting off as visceral pain, moving to somatic pain situation. Its etiology is pretty much there is some sort of blockage, usually by fecal lift, which is like semi-formed poo, blocking the entrance of the appendix from the cecum. And that causes just accumulation of bacteria in the area. It starts getting angry, we get inflammation and infection. Typically, we're going to have pain, starting in the periumbilical region, like we talked about, migrating to the rif, very commonly associated with nausea and vomiting. And obviously, because it's inflammation and infection, we can have fevers, sweats as well. Complication, mainly, we don't want it to perforate and burst. That would be bad. It will infect with bacteria, the normally very sterile peritoneal cavity. And so you get peritonitis, and if it gets into the blood, sepsis. Clinically, we want to be aware of McBurney's point, which is 2/3 of the way between the umbilicus and the aces. And if you point it, that's technically where the appendix should lie. Robsing sign is that you press the rif and there's pain in the lift because there's irritation of the parietal peritoneum. A rebound tenderness is when there's pain when you take it off. Again, just a sign of irritation of the parietal peritoneum. Notably, obturator and the psoas signs. So the appendix, as you would have learned in anatomy, can lie in a number of different positions. If it lies kind of a little bit lower down, more in the pelvic region, the obturator sign, which is this first image here, can cause pain. If it lies retrocecally, so behind the cecum rather than kind of just hanging out underneath, when you do this, it's called the psoas sign. You'll elicit pain there, and you can just imagine why, because when you're moving different muscles, it could irritate the appendix depending on where it is. Treatment is commonly just an appendicectomy, although I think there's like discussion about whether antibiotics also work, but for now, appendicectomy, just get it out. So I think you guys had an ICL on this, so should be all over this, but we'll just touch on this briefly because it is really, really important. It's the third most cancer in Australia, bowel or colorectal cancer. That means the same thing. The etiology is normally, we start off with normal epithelium, then you get a polyp, which is kind of just, hyperproliferation, then an adenoma, which is a precursor potentially to a carcinoma or a cancer. Genetics, you would have learned about familial adenomatous polyposis, which is an autosomal dominant condition, which can really, really predispose as an individual to getting colorectal cancer. I think it's got like 100% penetrance. So be aware of that. And a number of different mutations can also occur, just like any cancer. When you are taking a history, you want to be aware of all of those red flag symptoms. Yes, we will. Yes, Heini. Okay, cool. So sorry, we have to speed through this. I took too long on anatomy. So red flag symptoms, think about loss of weight, fatigue, fever, that kind of thing. Depending on where the cancer is, it's more likely to present a slightly different way. So a left-sided cancer, if you think about it, more likely to be that obstruction kind of symptom because you've got literally just a mass growing. If it's right-sided, it's more likely to be that kind of chronic bleeding that nobody really picks up on. So you end up with anemia and fatigue, all those types of constitutional symptoms as well. Rectal cancer, tenesmus, that feeling of incomplete evacuation because you've got something there in the rectum, and a PR bleed. Fecal blood test is part of the national bowel screening that we have in Australia. The main way that it's diagnosed is through a colonoscopy and a biopsy. So this is what that looks like. And yes. Okay, this is for Heine and I to remind you that, again, not all abdo pain things present as abdo pain. So rely really heavily on the history, and always, if you think loin to groin pain, you want to be thinking about renal stones, but we'll let the fantastic renal presenter for tomorrow cover that. Again, here, really classic faculty really likes to ask about presentations of ruptured ectopic pregnancies. And always first line investigation in a female of childbearing age will be a beta HCG. Okay, again, another presentation that can present with abdo pain, but is not necessarily part of the GIT. Hemodynamically unstable, sharp bang pain at the lower back. You want to be thinking of ruptured abdominal aortic aneurysm. So that's pretty much it. We just wanted to give you that classic presentation so you're able to pick it up in your MCQs or EMQs. This is a medical emergency. Typically, they'll present shocked, and it'll be an older male with cardiovascular comorbidities, particularly smoking. So, yay, we are at the tail end now before we get to liver, pancreas, all that kind of stuff. But we just want to be aware of this line called the pectinate line or the dentate line, because this is the difference between, in embryology, the endoderm, so it's kind of starting from the inside, and the ectoderm, so invaginating from the outside. Again, here, this is a little bit like the table that I made before for testes and scrotum, because you can kind of remember it in the same way. So just remember that one of it kind of drains kind of inside more to all of the systemic kind of stuff. And then below the pectinate line, it's going to be going around the outside more. And so everything else that we need to know is on this table. So thank goodness we are moving straight on.
That's still you, babe, and you're doing anatomy.
Oh, sorry. Okay. Sorry about that. So gallbladder and biliary tree, we do want to be aware of another triangle in the body. So if you want to know two triangles in the body, know Hasselbalch's and Callet's triangle. Callet's triangle has to do with during a cholecystectomy. So when they want to take the gallbladder out, surgeons will always try and visualize Callet's triangle. And the reason for this is because they want to ligate the cystic artery and the cystic duct in order to take the gallbladder out. So the borders of this are the common hepatic duct, as you can see, the cystic duct, and the inferior border of the liver. As you can see, most of the time the cystic artery runs in this way. Okay, bile, the main purpose of bile, which is created by the liver and stored and concentrated in the gallbladder, is to emulsify fats with the bile salts. Just to emulsify fats, basically to help with the breakdown of fats, so your pancreatic lipases can get to it a little bit easier, break it down into its parts. So basically, it just gets to the fat droplets before pancreatic lipase does. And it breaks it down to smaller emulsion droplets because it has a hydrophilic and hydrophobic bit. And this means that your pancreatic lipase just pretty much has more surface area to act on that fat droplet. So it breaks that triglyceride down into a monoglyceride and fatty acid, actually on like 3 fatty acids, which can diffuse into the intestinal epithelial cells. Here, there's a little bit of like a back and forth situation where we make micelles and then we unmake micelles. Unmake's not a word, but we break them back down again. And the way this is kind of decided, if you just remember, is based on the concentration gradients. Cool. So which one do we need more of at that time, depending on which one do we have less of? So after this, the fatty products will just be absorbed down the concentration gradient into the bloodstream for transport and redistribution and storage in other organs. Bile secretion, we want to be aware of 2 molecules, secretin and cholecystokinin, or CCK. So always, the way I went about remembering this is what causes the release of that molecule is going to determine what it does, which kind of makes sense. So the acidity of chyme coming in from the stomach entering the duodenum is going to cause the enteroendocrine cells of the duodenum to release secretin. And remember, this was activated, or this was released by the acidity of the chyme. Because of this, we want to find something to combat that. So the secretin is therefore also known as nature's antacid, because it's going to cause secretion of a bicarb, which is an alkaline fluid. Cool. So triggered by acid, we're going to combat that with bicarb, secretin. CCK is triggered by the presence of fats. Because of this, we're going to cause the gallbladder to contract to release that bile to break down that fat. Makes sense. It will also cause the sphincter of Oddi to relax just so we can let the bile through. So it makes sense. And also, remember, we want to break down fats. The pancreas will produce enzymes as well because of CCK stimulation. Okay.
Okay, we have a 50-year-old female. She presents with fever, jaundice, right upper quadrant pain. What's our differentials? We haven't even really been given time for, yeah. Anyway, basically ascending cholangitis. Cool. So we're going to go through some gallstone pathologies, give Eugene a bit of a break. So these are all the gallstone pathologies. They look the same, but I promise there's a difference. They're very, very different. So the way that we remember them is that anything with stones is lithiasis. Anything with inflammation is itis. Just remember it that way, and you're already half the way there. So cholelithiasis is your classic gallstones. I think basically on EMQs, MCQs, they're generally presenting as like asymptomatic, but they can present with colicky pain as well in real life. No jaundice unless the gallstone is actually like compressing. There's like biliary obstruction. But basically in a general MCQ situation, there's not going to be any jaundice. Treatment, cholecystectomy, unless they're asymptomatic, which is a lot of the time. So then it's just going to be no treatment. So choledocholithiasis is stones in the bile duct. Also asymptomatic, but generally in an MCQ, EMQ situation, they're going to have obstructive jaundice symptoms as well as colicky pain. So that differentiates it from cholelithiasis. Treatment is ERCP, none, once again, if they're asymptomatic. So your inflammation kind of based conditions. So cholecystitis is gallbladder inflammation. And this is where you get a positive Murphy sign. We are going to go through all of the clinical signs, I promise. We're going to get to them at the end. And treatment is cholecystectomy, supportive care, antibiotics. And then we have cholangitis, which is basically like your bad one. We don't like this. So that's bile duct inflammation. And generally it's ascending cholangitis. You can get descending, which is where it comes from the liver. However, not as common, very, very much so. It's always going to be ascending cholangitis. And this is where you get Reynolds pentad, which is basically Charcot's triad, which is just right upper quadrant pain, jaundice, fever, as well as shock, which will give you hypertension, tachycardia, as well as an altered mental state. So treatment, fluid reflux, give them IV antibiotics, supportive therapy, and potentially do ERCP or surgery. We do have big tables. I think the main thing, if you just go back, go to the next slide. I think the main thing to remember is cholelithiasis is the one with the 5 Fs. So fair, fat, female, fertile, and over 40. And those are just like the main risk factors to remember for someone potentially presenting. I think everything else is basically all of the information is in these tables that you need to know. And yeah, cute. Oh, pancreas is back to Eugene, sorry.
Okay, cool. So we want to be aware that the pancreas is kind of like two organs operating under disguise as one, because they have two very, very different functions. You want to remember that the exocrine pancreas releases stuff outside of the body. If you think about it, the gut tube is kind of technically outside the body. Like we haven't actually passed through any bit of epithelium yet to go into our tissues. So because of that, exocrine pancreas releasing stuff into the gut tube is going to be the digestive enzymes, and the bits that do this are the acinar cells of the pancreas. The endocrine pancreas, on the other hand, think about like endocrinology, hormones, right? So we're going to be releasing hormones into the blood, namely to regulate blood sugar levels. So we want to really focus on the alpha and the beta cells in the islets of Langerhans. The alpha cells secrete glucagon, and what glucagon does is it will help to increase blood sugar levels. And so beta cells are stimulated to release insulin to lower blood sugar levels when blood sugar levels are high. Okay. Really, really, really classic presentation that we have here. If you have epigastric pain associated with nausea and vomiting that radiates to the back immediately, you are going to say that this is acute pancreatitis. So maybe not that immediate. Do look through the other options, but high likelihood that it's going to be acute pancreatitis. So Sorry. Sorry. So with acute pancreatitis, we do want to remember the acronym I get smashed, but really you just need to remember the GE part. Gallstones and alcohol are the two top causes for acute pancreatitis. Do not tell a consultant scorpion bite when they ask you what causes acute pancreatitis. Everyone remembers it, but don't say it. So gallstones and alcohol. Cool. Presents typically like the case that we just showed you before, epigastric pain radiating to the back, alleviated by leaning forwards, just because if you remember, the bulk of the pancreas is retroperitoneal. So very, very, very commonly associated with nausea and vomiting, can also be in your MCQs presented as a patient who's post-ERCP. So the procedure that Heini talked about before, because pancreatitis is a known complication of ERCP or a known consequence or adverse effect of ERCP. So there are a few signs that we want to be aware of: Gray-Turner's and Cullen's sign. Heini will go through this more in more detail later. Jaundice if it's a gallstone etiology. If you are asked what investigation you want to do and it's acute pancreatitis, don't go for imaging first. You want to get lipase. So that's more specific than amylase. So you might see lipase and amylase. If those two are your options, pick the lipase because it's more specific. You can also do CT abdo to characterize the inflammation and everything. Treatment is mainly supportive, or grabbing out the gallstones if that's what's causing it. Cool. So we want to be aware that in the liver, so moving on to the new organ now, in the liver, there are two different ways of dividing it, anatomically and physiologically. There are 8 segments, and it's important to note that each of these segments is supplied by one branch of the portal triad. Because of that, it's not supplied. Each segment is not supplied by a tributary of the hepatic vein, because the hepatic vein is not part of the portal triad. So if you recall again, the portal triad is going to be your bile duct, hepatic artery, and portal vein. So quickly anatomy here, it's pretty much self-explanatory. We can kind of look, when we look at the liver microscopically, it can kind of look like hexagons, 3 hexagons all grouped around the portal triad here. And so mainly we just want to remember what that is again, or what's in the portal triad. When we think about the liver, I think a really good place to start is thinking about what the liver does. And when the liver's not happy, it's basically not going to be doing all the things that it normally does. So if we remember, it stores a bunch of stuff, namely like our sugars and things. It helps break things down. It helps to process toxins. It helps to conjugate bilirubin. And it is also involved in, androgen breakdown. And it's also synthesizing a lot of protein. So albumin, the most plentiful protein in the body, in the blood, and then your clotting factors as well. So what is bilirubin? It's basically a breakdown product of old red blood cells. So red blood cells are broken down by macrophages just in the blood. And the heme part is broken down into iron and biliverdin. And this biliverdin is then just in the blood also made into unconjugated bilirubin. It is this unconjugated bilirubin which the liver greets for the first time, and the liver makes it into conjugated bilirubin, excretes it as part of the bile. And it's the bacteria in the colon that deconjugate this bilirubin and make it into urobilinogen. 80% of urobilinogen will become stercobilin, and this is and it's excreted in the poo, and that's what makes the poo brown. 20% of the urobilinogen will stay as urobilinogen and be reabsorbed into the bloodstream, find its way to the kidneys, where the kidneys convert it to urobilin and excrete it in urine. So that's the pathway to understand. And this becomes important when we want to talk about jaundice. So Heini, you're up.
Great, LFTs. We love LFTs. Basically, in general, as a general rule, just know what each test is looking for. You don't need to go into a lot of specific detail. That's more of a third year thing. It makes it easier to kind of interpret and just get what everything is talking about if you do know generally what's going on though. You don't need to know reference ranges, by the way. They will tell you in general if it's high, if it's normal, what's going on. But if you want to be a smart cookie and just know the reference ranges for yourself, just so you know, if they do give you values, you know if something's horrendously going wrong. Cool. So I have lost my spot in my notes, so we're just going to go off this. Great. So we've got AST, ALT, or transaminases. So that is basically hepatocellular damage. So what we're doing is we're looking at the ratio of AST to ALT. Just know that ALT is more specific for liver damage. So I still haven't found my spot. So AST to ALT, if that's greater than 2, basically alcoholic hepatitis. And it's quite specific for that. If the ratio is equal to 1, that's generally associated with ischemia, such as like congestive heart failure, ischemic necrosis, hepatitis. There's a lot more examples that you can go find yourself if you want, but just know some basic general ones. And so if the ratio is less than 1, which means that there's a very high ALT, that's basically, as we mentioned before, because ALT is more specific for liver damage, it's going to be a marker of hepatocellular injury. So that's like your viral hepatitis, paracetamol overdose, ischemic hepatitis, etc. There's a lot of examples, but just know a few. And then you've got your ALP GGT, and this is your elevation with cholestasis. So basically you just need to remember like the 2 categories, hepatocellular damage and cholestasis. So ALP is cholestasis, malignant hepatic infiltration. So that's generally with a biliary obstruction. And GGT, just know, sensitive to alcohol. Yeah, and like I've put a lot of information in these slides. We're not really going to go through them today, but just this is for your information if you want to know more about it. And then we have the real LFTs. Not that there are fake LFTs, but these are the sort of real LFTs. So we've got bilirubin, which we've already kind of talked about. Albumin synthesized in the liver, it maintains the oncotic pressure of blood. So this can fall if there is presence of liver disease such as cirrhosis, any inflammation, as well as nephrotic syndrome. We've got INR, and you guys are going to go through this in a lot more detail when you do heme, which is next sem, the very start of next sem. And basically this is a standardized version of something called prothrombin time, which basically measures the extrinsic pathway of the coagulation cascade. And because the liver synthesizes these clotting factors, basically if there's a prolonged INR, it can be a sign of liver dysfunction. And then platelets. Liver produces thrombopoietin, which is a growth factor for platelets, and basically thrombocytopenia, which is low platelets, can be a sign of liver dysfunction as well. So anything that goes wrong with the stuff that the liver does, this is where you'll see it. Okay, this is your cheat sheet, broadly speaking, but like in terms of what faculty likes to ask, and they'll usually give you like a table, like not with the answer part, but like they'll give you the table of like, okay, normal, 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 and then elevated. What is this a sign of? And you'll just go alcohol binge because it's GGT. And like, if you can't be bothered memorizing what the LFTs do, this is kind of your way of getting out of memorizing the other stuff and just memorizing this table instead. Which one's easier? You guys can decide for yourself. But yeah, if you don't have time, just have a look at this instead. Great. Jaundice. We love jaundice. So there's prehepatic, intrahepatic, and posthepatic jaundice. Just to kind of the main things to remember. So prehepatic is going to be your unconjugated elevated bilirubin. And this is basically the one thing to remember. It's like hemolysis. So like hemolytic anemias and stuff like that. Intrahepatic is your mixed elevated bilirubin. So you're going to have a high AST, ALT, and this is a marker for hepatocellular damage. So you're going to have dark urine, as well as potentially pruritus, which is basically like when you get like itchy, and that's because of the bile buildup. And then you've got post-hepatic jaundice, which is your conjugated elevated bilirubin, which is your high ALP GGT, and this is usually due to an obstruction, so cholestatic. And this is when you're going to get your pale stools, dark urine, as well as the pruritus because of that bile buildup. Great. Sorry, this is very, very, very brief going through, but I promise you everything that you need to know is on this slide. We're just not going through it in a lot of detail. Also, here's a summary diagram. If there's like too many words going on for you, here is a summary diagram for you that makes it even more simple. I think the main thing to also know is just like they do ask like urine and stool color. So do like know that. Do we have time for questions? Probably not. Let's move on. But these are good questions in terms of this is how they ask like MCQs in terms of LFTs. Like here are the pathology results, interpret them for us. Cool. And once again, I will get to the questions once we finish, but I've just got like a lot of things to get through. Great. So we have a presentation, right upper quadrant pain and fever in a returned traveler. What is our differential? viral hepatitis, basically, most likely HAV in this particular case. So we have some important clinical conditions. We have a lot of them basically for the liver, but we're going to go through viral hepatitis just for now. So we've got a few different types. So hepatitis A, transmission is fecal oral route. So basically in contaminated food and water. We do have a vaccination for this. There is a potential to develop into fulminant hepatitis, which is like a very severe hepatitis, but it's very rare. Basically your buzzword that you want to know is return traveler with right upper quadrant pain and jaundice, because we love buzzwords in med. So if you see this, think, there we go. Hepatitis B transmission is blood and body fluids. We also have a vaccination for this. There is a potential that it will develop into a chronic infection. This is the same with hepatitis C as well. And then hepatitis D doesn't really ever get mentioned, but know it for like FYI. It can only exist in the presence of hepatitis A. Great. Do I have more? I have more. Yes. So presentation, kind of that classic presentation that we already went through. Just some risk factors. Hepatitis A is going to be a returned traveler, contaminated food. All of the rest is going to be like your IV drug users, unprotected sex, or unsafe tattoos. And usually in an EMQ, because it's an EMQ, they're going to have like all three, just because they list all of your risk factors out for you. I think everything else on the slide, we are running short on time. So great. So they will ask about this. If you go to the next slide, I'll just show the table. So this is like your Hep B serology, and they do ask this quite often. So what you just want to know is that your surface antigen is when it's a current infection. So on the, it's just like surface. Your E antigen is highly infective, and it's only, you can only get it like the serology when the virus is actively like replicating at that time. Surface antibody is basically cured. And then your core antibody is only present if there has been a past exposure and then they have recovered from that. So you're just know like your IgM, IgG. So IgM is recent, IgG is old. And they like asking like vaccinated as well as past infection a lot. It's happened in quite a few past MCQs. Great, and I think this is more detailed explanation if you want that. And then there's another question that you guys can go through in your own time. How are we going for time?
Okay, I think we're going pretty okay. I'm not sure if you saw my message, but Jasmine's lecture is 1 hour, so we have a little bit of leeway. Okay, but we will speed through this. There is a question that I'll just answer with words. First, regarding how important treatment and diagnosis are for clinical conditions, apart from the pharmacology that we learn, you want to know like certain things. So for instance, when do we opt for a medical route? When do we opt for, you know, more of a surgical route kind of situation? Regarding like the specificities, no, you don't need to know that unless it's like in your syllabus or in your lectures. But always remember as well, you know, when you're doing your Monskis or your Oskis and things like that, just remember like lifestyle things that you can change to can come up in situations like that. So one more thing that I just want to clarify, there was a typo on the previous slide about the viral hepatitis. Hepatitis D requires hepatitis B to replicate, not Hep A. Yeah, so just wanted to clarify that just in case. Okay, so liver cirrhosis is bad. Basically, it's when there's irreversible damage to the liver, where your normal, healthy, happy, functional hepatocytes have been replaced by scarring of fibrous issue because of a chronic insult. So if we take a look at these diagrams here, there are two main types of like liver disease or chronic liver disease that you'll come across, and that is alcoholic liver disease and non-alcoholic fatty liver disease. So as you can see, when we're at this kind of fatty stage or the hepatitis stage, abstaining from alcohol can still, you know, cause the liver to regenerate again, because the liver has an incredible capacity to regenerate back to normal liver. But once we get to the cirrhosis stage, that's there's no going back from that. So we already talked about that. Yes, basically any chronic insult to the liver can cause cirrhosis. The main consequences that we want to be aware of are basically the liver will not do the job that it's meant to do. Your liver makes clotting factors. So in cirrhosis, it does not make clotting factors, which means that you bruise more easily, you bleed more easily. The liver makes TPO. If we don't make TPO, you're going to have low platelets, like Heine talked about. We're not going to process bilirubin, and so there's jaundice. We're not going to process ammonia, and there's buildup of toxins, so that can affect the brain with hepatic encephalopathy. The liver's not making albumin, and so you have hyperalbuminemia, which you remember the whole oncotic pressure situation means that we end up with edema and ascites. This can also progress to hepatocellular carcinoma, and so that's why people with liver cirrhosis get 6 monthly, I think, screens for that. The main one that I will talk about, though, is portal hypertension, just because that ties in really, really closely with anatomy. So basically, when you have this architectural change in the liver, in cirrhosis, what happens is that it kind of disrupts the blood flow in a way that there is an increased pressure in the blood flow there, namely in the portal system, because you remember that the portal vein drains blood into the liver. And the liver is the way that blood from the portal system leaves through the hepatic vein back into the IVC, back into the rest of the body. Cool. So when we have portal hypertension, we've got disruption of blood flow here. It's a little bit like a roadblock. So what's going to happen is the blood will try to find other sites to go to get from the portal system back into the systemic or the cable system. On the slide here, we've got 3 key ones to remember. There are more than this, but these are the 3 ones that come up most frequently in exams and stuff. So I want to be aware of, and the most kind of clinically important one, because if they bleed, it's a medical emergency, it's life-threatening, is esophageal varices. And these form from the left gastric vein, which is from the portal system, and the esophageal vein, which drains into the esophagus, which is the systemic system. So portosystemic anastomosis here. So normally, not a lot of blood goes through here, but in portal hypertension, they can become really engorged and it creates esophageal varices. If this bleeds, it can result in a massive upper GI bleed, so massive hematemesis, medical emergency, life-threatening. Caput medusae, which is a sign that you've been taught to look for in clinical skills, is also an example of this. So the periumbilical and the epigastric veins of the anterior abdominal wall, and that's why it manifests in this way. Now, the superior rectal vein also anastomoses with the inferior and middle rectal veins, kind of in the same way that superior rectal artery from the IMA does, if you remember with the arteries. So veins, just flip that on its head. Same kind of situation though, arteries and veins. This results in anorectal varices. And as far as Heine and I are concerned, these are different to internal hemorrhoids. So just note that, because sometimes you'll see in different texts, I think sometimes they can get confused, but they're different because hemorrhoids don't really have anything to do with the portal venous system. It's all kind of just the systemic there. Okay, Heine.
Great, spleen. We love the spleen. We don't really know what the spleen does either, but like whatever, no one really does. Cool, great. Let's go through it very, very quickly. It's an intraperitoneal organ. It's located in the left upper quadrant behind ribs 9 to 11 near the pancreatic tail. Obviously, you know how it tickles the spleen. Anyway, basically, main thing to know is that if you have broken ribs, especially like the lower ones, you can lead to a splenic rupture. And honestly, most of the information you need to know is on this slide, but if someone has had their spleen taken out, they are at an increased risk of infection. So you need to like re-emphasize to them that getting their vaccinations is really, really important. And they're at a particular risk with like encapsulated bacteria just because they don't have the ability to actually deal with that. What even is the spleen? We don't really know. There's not actually. Okay, great. We're finally up to clinical signs and pathology. So this is where we're going to go through all of those signs that we didn't actually go through when we were actually talking about them. Great. Does anyone know what Murphy's is? This is a bit of interaction, guys. I do need answers. Yes. Can anyone describe what you would do? Yes. Great. So basically, what happens is that the patient will actually like catch their breath when you push down on the right upper quadrant. So basically, it's when the gallbladder actually like comes into contact with your hand, and it's gonna hurt, and they're gonna go like it'll like you'll be able to tell. And great, acute cholecystitis. Okay, I can never pronounce this, Courvoisier's or whatever, however you pronounce it. It's probably French. Great, anyone can tell me what this is? Basically, this is a palpable gallbladder, usually, so it's a painless, non-tender mass that you can feel, as well as mild jaundice. It's basically pancreatic or biliary malignancy until proven otherwise. However, I do need to make this clear that just because it is painful doesn't mean that it's not a pancreatic tumor, right? Like, this is just a sign that you get taught to know that it's pancreatic or biliary malignancy until proven otherwise. But if they do have pain, don't just say, oh, it's not pancreatic tumor just because they have pain. Okay, what's Gray Turner's? Amazing. So Gray Turner's is discoloration of the flanks, basically acute pancreatitis. We've already kind of covered this. And what's Cullen's? Amazing. So I think a lot of people remember that C central, or like it makes that kind of shape around the umbilicus. So that's Cullen's is center, Gray Turner's is the other one. So it's on your flank. So both of these are acute pancreatitis. What's McBurney's? Cool. So basically, yeah, a sign of acute appendicitis. And basically, it's the point where you press down and you're going to elicit pain. But basically, it's a third of the distance from the ACEs to the umbilicus, or it can be 2/3 from the umbilicus to the ACEs, like it's depending on where you actually calculate it from. And last one. Amazing. Appendicitis. So there's pain in the riff when you're palpating the liff. Okay, last two that are important. Rebound tenderness. Yep, amazing. So peritonitis, basically there's pain. So you actually have to press down and then lift up quickly. It's not just you're doing normal palpation and you're going to get rebound tenderness. If they have like severe pain, probably, but it's, you actually have to, especially when you're doing your OSCEs, you have to show that you're looking for rebound tenderness. You press down, lift up really quickly. And then shifting dullness. Ascites, yes. Anyone know how we get it? Oh, we'll go through it. So basically dull percussion on the sides of the abdomen, and then it becomes resonant when the patient turns on their side. So it's literally, if you think about it, it's like where the fluid settles. So when they're lying on their back, it's going to be on the sides. And then when you kind of get them to turn over, it's going to turn resonant basically, because the fluid all shifts. And you actually need to, like, especially in your OSCEs or in a real life situation, you actually need to wait. You can't just get them to turn on their side and immediately go in and start percussing, because it's not, the fluid hasn't settled yet, but when you actually like go start immediately. That's just tip for OSCEs. Cool. And those are just some pictures for your information. Oh, Adrian, can we just go back to the previous slide just for, I think it was, wait. Go back further to the first slide. Yeah, there we go. For anyone who needs a photo. Great. And yes, we do have lots of questions, but I think you can do those in your own time. So acute upper and lower GI bleeds. Basically, they can manifest as either an overt GI bleed or an occult GI bleed, so with the symptoms. So occult GI bleed is basically they're going to present with non-specific symptoms that are related to stuff like iron deficiency anemia, because they are bleeding. So they're going to have those kinds of symptoms. Basically, management of an overt bleed, you want to make sure that the patient is okay. So hemodynamically stable. If they're not, ABCDE approach, you don't actually need to know this in terms of like a second year level, I don't think, but just cool for like your information. This is what you do, ABCDE. You want to find out where is the bleed, right? Because you want to go in and you want to stop the bleed. Wow, amazing. And just some things to note. So bleeding from the upper respiratory tract, such as like severe nosebleeds, can actually be mistaken for a GI bleed. It's because that blood can be swallowed and it can like manifest as like hematemesis or melena. So you just want to make sure you take a really good history, because you don't want to be going on and like investigating GI bleeds when you ask the patient and it's just like, oh, I had a really, really bad nosebleed and I swallowed a lot of blood. Also, unexplained iron deficiency anemia, such as in men, should always raise suspicions of a GI bleed, because iron deficiency anemia is not that common. So you always want to think, okay, maybe it's a GI bleed. We had some causes listed there as well. Those are just for you to go through in your own time if you would like. Wait, go back. I think we just wanted to go through hematemesis, melena, and hematochezia. So hematemesis, melena are your upper GI bleed signs. So hematemesis, vomiting blood, it can either be red or it can be coffee ground. I think coffee ground is usually in like OSCE questions, not OSCE questions, like MCQs. Melena is your black tarry stool with an offensive odor. And this is basically, both of them is just because like the blood has been like digested, and that's why it has that color. And hematochezia is bright red frank blood. Depending on where the bleed is, like the location, it can manifest in different ways in terms of like the stool. So you can either have the maroon kind of traces in the stool, or you can have like streaks of fresh blood. And this is usually a lower GI bleed. It can be an upper GI bleed, very rarely if there's like a really rapid passage, but don't worry. Okay, cool. We're going to skip basically some of this abdo pain, like patterns, all of the stuff is on the slides, but it is quite important to know. Do we want to, actually, no, we'll talk about, yeah, just like some other signs. Constipation, basically, I feel like we've all experienced this before, infrequent passage of stools. Depending on like numbers, like it's either less than 2 or 3 times a week. What else do I want to talk about? Management is just basically identify, treat the underlying cause. You want to increase their fiber content, best done naturally, but you can give them supplementation as well. Regular exercise, hydration. You can also give them laxatives, but yeah, we're going to talk through pharmacology as well. These are some causes. There's primary and secondary causes of constipation. Basically, primary is something to do with like the actual function, secondary related to a disease. They're all there. You can have a look yourself, but we just need to push through. Okay, diarrhea, basically other opposite of the spectrum, excess stool. There's more frequent, more volume, a lot of fluid, usually acute, 3 to 7 days, but they can become persistent or chronic. And there's a few different types. They've all been explained here, and I do realize we are pressed for time, so we are going to keep going. Basically, find the cause and then treat the cause. That's literally main thing to do with a lot of these. So you've got acute, chronic. Acute is usually caused by infection. Chronic, you've got those 4 causes there. Infectious causes. Okay, let's go through microbiome. Jesus Christ. We'll go through the main ones of microbiome. The rest you can go through in your own time. Viral gastro, very, very common. Norovirus is most common in adults. Rotavirus is most common in children. Norovirus, hell breaks loose in terms of like hospital outbreaks. It's horrendous to deal with. It's awful. Basically, both of these are self-limiting, like just they resolve by themselves. You just want to give them supportive care and fluids because you don't want them to die of like dehydration. So just make sure you're giving them fluids, just treating that. Cool, let's move on. I'm trying to get through this quickly. GIT infections in terms of bacteria. We've got E. coli, salmonella. I think main thing to know for E. coli is that you've got 2 different types. So you've got the traveler's diarrhea, which is going to be non-bloody. That's the enterotoxin caused one. And then you've got the hemorrhagic E. coli, which is your bloody diarrhea. I think just to know with that one, don't give them antibiotics because you do have a risk of developing hemolytic uremic syndrome. Salmonella, basically, what do I feel like we all kind of know, contaminated chicken and eggs. Treatment is ceftriaxone, ciprofloxacin, azithromycin. C. difficile, very important because it's an opportunistic infection, usually happens after there has been antibiotic treatment for a different infection. And it's also called pseudomembranous colitis, basically watery diarrhea plus or minus fever, no fever, depending. And basically your treatment is stop the antibiotics that they're on, give them metronidazole, vancomycin, and a fecal transplant. And then cholera, basically buzzword, rice water stools. It's from food, and then you can look at the treatments yourself. And listeria, I think the main thing, if you go back, is just pregnant women. Bad for the baby. We don't like it. Yes, great. Yeah, basically the rest you can just go through yourself. Do we want to go through? Yes, okay, great. Pharmacology. Great, guys, we're nearly there. Pharmacology. So PPIs, we love PPIs, gold standard treatment. They're fantastic. Mechanism of action, basically it's an irreversible inhibition of the H plus K plus proton pump, so i.e. proton pump inhibitor. So basically overall, there's going to be a reduction in production of stomach acid because it blocks acid secretion on the luminal side of the parietal cells. And it's much more effective than using antihistamines or like antimuscarinic agents. Indications, basically triple therapy, GORD, PUD, and they're generally well tolerated. Rare side effect, which is FYI, I didn't know this either, gynecomastia. And this is basically a general diagram for where everything acts, just for your information. Clarithromycin, basically, it's in the H. pylori triple therapy. It's a macrolide. That's all you kind of really need to know. Zantac, it's the histamine receptor antagonist. So it blocks histamine-induced gastric acid secretion. Main thing to note is nocturnal acid secretion, and it promotes the healing of duodenal ulcers. So those are like your two main things to know about this one. Oh, okay. And then we've got sucralfate. I never know how to say any of these drugs. Basically, it's the viscous sticky paste, which binds selectively to the base of the peptic ulcer. Main thing to note is that you can't give an antacid at the same time because it's going to be less effective because it works in acidic conditions. So don't give them antacid or it's, it's not going to work as well. I think main adverse effect to note is aluminium toxicity. And misoprostol, however you want to talk about it. Basically, prostaglandin analog. Main thing to note is that contraindicated in pregnancy because it will help induce birth by stimulating uterine contraction. So that's a bit of a yikes if you give a pregnant woman this, like not great for both of you. Antacids, basically kind of in the name, it's a weak base which neutralizes the acid and raises the pH within the stomach. Therefore, it's going to provide symptomatic relief for about 2 hours, up to 2 hours. Indications, GORD. Constipation, Jesus Christ. Okay, guys. If we go to the next slide, I've basically given you the table. All the information you need to know is in this table, I promise you. Your two core drugs that you need to know is lactulose and senna. Get used a lot in hospitals, just for FYI, for when you go into clin years, used a lot. Cool, I think we're just gonna skip so we can, and then fecal softeners, basically it's a weak laxative effect. Diarrhea, usually self-resolving, but on the rare occasion that you need to give them drugs, we're going to give them antidiarrheal agents. Main one is opioids, muscarinic antagonists, not exactly great because they're not selective. If we move, basically loperamide is your core, it's on your core drug list, so know that one, but loperamide is the one that you will use. Antiemetics, I think the main one, gold standard, is ondansetron. And basically it blocks serotonin receptors in the CTZ as well as the GIT. So you're going to have peripheral and central effects. And I think mainly that's like your gold standard. Honestly, guys, I promise you, everything that you need to know about these drugs is on these slides. This is why I'm not going through them in detail. Yes, and also here's another diagram. We love summary diagrams. Here you go. Yeah, well, there's questions. Nutrition, just read as you go along, basically. I think just the main thing to note is RDI, so that's the average daily amount needed to meet requirements of nearly all healthy people. There was a question on this in our exam, so just know it. And great, I think we're going to go very quickly through clean skills. So the abdo exam, I think main thing everyone needs to remember is that you always need to start with general inspection. So the thing, like they're all listed there, but I think a lot of people forget mental state. So because of hepatic encephalopathy, just want to make sure that they're like, okay, so you just, you can read this yourself basically, but cool. Abdo exam, all of the things listed there. And sorry guys, that was a really big rush, but thank you for listening to us rush through all of GIT.